Amis téléspectateurs, bienvenue à Face à Face. Aujourd'hui, nous ouvrons notre page médicale sur le chapitre du cancer, particulièrement le cancer de la prostate. Parmi les maladies qui causent un tollé annuel de morts ici aux États-Unis, les statistiques accusent le cancer comme l'une des premières à affecter notre population. Quelle que soit la forme de présentation, le cancer demeure un casse-tête pour les médecins pratiquants, les scientistes et chercheurs. Les travaux de laboratoire continuent encore afin de, sinon découvrir les causes de ce mal, du moins lui trouver une cure. Les méthodes actuelles de traitement, telles la radiation, la thérapie chimique, le traitement des hormones, etc., ne sont pas totalement garanties puisqu'il existe une possibilité de retour de la maladie. Les formes de cancer étant si multiples, nous nous proposons de faire un peu de lumière sur celle de la prostate avec l'aide de notre invité spécial, le docteur Gary Weiss. Dr. Weiss est un urologue spécialisé dans le traitement du cancer, particulièrement le cancer de la prostate. Il est un médecin pratiquant à Long Island Jewish Hospital et également professeur associé à Albert Einstein's College of Medicine. Let's say welcome, Dr. Weiss. Chers amis, également, nous a rejoint aujourd'hui notre documentaliste à face, M. Étienne Télémac, actuellement présent. Nous disons bienvenue à Étienne.
Bienvenue.
Une exception au format de face à face aujourd'hui, cette entrevue sera faite dans la langue de l'invité qui est l'anglais. Again, welcome, Dr. Weiss.
Thank you. It's nice to be here.
Since we're going to be talking about prostate cancer, let me ask you the first question. Can you define for us what cancer is?
Cancer is an abnormal growth that can grow locally and invade adjacent organs, invade normal tissues and disrupt them. And it's a growth that can travel through the bloodstream or through the lymphatic channels and take up residence at sites foreign from where it first began. So a cancer that arises in the prostate can grow within the prostate, destroy the normal structure of the prostate, grow beyond the normal confines of the prostate, and destroy adjacent tissues and organs, and can spread to the lymph nodes, can spread to the bone. When you have prostate cancer that spread distantly at a late stage in the disease, and it resides in the bone and is growing in the bone and causing damage and pain, some people talk about that as being bone cancer, but to a physician, it's prostate cancer that has spread to the bone. It's metastasized.
Okay, let's focus on prostate cancer since it's the subject of our interview today. Will the prostate cancer affect most males, right?
Prostate cancer is a very common cancer. It is among men, not women, but among men, is the most commonly occurring cancer, but fortunately most men will not get it. In the United States, there will be 165,000 new cases diagnosed this year. That over the course of a man's lifetime in the United States has about an 8% chance, about 1 in 11, of getting prostate cancer. It's a little bit higher for African American men. It's about 1 in 10 chances over the course of his lifetime of getting prostate cancer.
Okay. Can we have an idea about the real cause of this prostate cancer? And doctor, would you define really what is a prostate?
Okay, I'll take the second question first, and maybe this diagram will help us a little bit. The prostate is a gland that's underneath the bladder, it's in front of the rectum, and it's behind the pubic bone, which would be over here. The testicle makes sperm. The sperm travel through the vas deferens and go through a tunnel called the ejaculatory duct in the prostate and then enter the urinary system. When that happens, when a man ejaculates, when the sperm comes out through the penis, this part of the prostate contracts so that the sperm won't travel back into the bladder. Outside of times of sex, this tube remains closed, nothing travels through it, and the urine, when it passes through the urinary passageway, it travels through the tunnel through the prostate. The prostate provides a pathway for sperm, prevents it from getting into the bladder, allows urine to travel out. It also makes secretions that help sperm perform their function in fertilization.
That's a very important organ, right?
Very important, both in terms of urinary control and in emptying your urine, as well as in fertility and men being able to father children.
Okay, and for prostate cancer, what are the symptoms? Is there any that we can relate to if somebody feels something that you can see without detection, proper detection?
I'll answer this question now, but I want to get back to Etienne's question about possible causes of prostate cancer. Some men have prostate cancer that's clinically important, and yet they don't have any symptoms. But the sort of symptoms that one might make you think about the presence of prostate cancer would be blood in the urine. In an older gentleman, someone over maybe 50, blood in the ejaculate. Blood in the sperm, in the ejaculate, can happen in younger men. Men, when it happens when they're 20 or 30, it's actually not, while it looks alarming, it's usually nothing very bad. But in men above 50, blood in the ejaculate may be a sign of prostate cancer. Blood in the urine at any age is an alarming sign and should be investigated. Sometimes is related to prostate cancer. When the prostate becomes enlarged, it tends to close off the urinary passageway. This can be due to benign growth that's not cancerous, or it can be due to cancerous growth. When the urinary passageway becomes narrowed, people run to the bathroom more frequently. It's a little bit harder to get the urination started. It may take more time. They may have to push a little bit. They may wake up more times at night to go to the bathroom. If it's hard for the bladder to push the urine out, the bladder may not be able to empty completely each time, so it fills up faster. If it only empties halfway, it quickly gets full again. So those are sometimes there's also a little bit of pain or burning with urination. That can be due to infection or to problems with blockage. So difficulties in urination related to more frequent, slower, weaker stream, more often, a sense of not emptying completely. These are all things that should be investigated by a physician, preferably a urologist. They may be perfectly benign, not having to do with cancer, but they may, and it needs to be sorted out and addressed.
Okay, now without
back to causes.
Okay, let's go.
In answer to Etienne's question, there's a lot we don't know about cancer in general. We know that for cancer in general, there are changes that occur in normal cells and normal constituent parts of your body in the genetic information, the information that tells cells how to work. That when they become abnormal, when they lack the proper instructions for controlling their growth, can result in uncontrolled growth and spread of bad cells, bad constituent parts of the body, and result in cancer. One of the things that seems to be implied for a lot of cancers is the high fat in the American diet. It seems to be the case for colon cancer. It may be the case for breast. It may be the case for prostate cancer. It's not certain, but together with what's known about the adverse effect, the bad effect on the heart from high-fat diets, and what's known about its bad effect for colon cancer, we have plenty of cause to decrease the amount of fat we eat, the percent of fat in our diet, and it probably will have a beneficial effect in terms of prostate cancer. It's thought that the fat might influence the development of the prostate cancer, help it along. There seems to be a genetic component to prostate cancer. Some prostate cancer occurs in men who are quite young. By quite young, I mean in their 40s or 50s. A large fraction of these men often have relatives who had prostate cancer, and a large fraction of these seem to have been due to inherited genetic changes. But even among young men who don't have any relatives who have prostate cancer, you can occasionally find some cases.
Wow. What is the relationship between the social status and the occurrence of cancer? Is there any correlation?
In some malignancies, it seems that the lower the socioeconomic class, the more of a particular cancer you have, the more mortality, more death you have from that disease. And often it's thought that it's lack of access to health care that leads to it. Sometimes it's thought to be more exposure to environmental carcinogens. For prostate cancer, there's not a clear socioeconomic correlation with incidence. It's the incidence of prostate cancer, the frequency with which people get it, seems to be higher in countries that are industrialized and have high socioeconomic status or high GNPs per capita compared to many third world countries. The amount of prostate cancer is relatively low in Africa and India and Japan. Japan is an industrialized country that's not European, so it's not a tight correlation. African men in Africa don't have very high prostate cancer rates compared to the men in the United States. In the United States, African American men have a higher prostate cancer rate not only than African men, but than white American men. So it's not a clear issue. If people move from India to the United States, the risk of getting prostate cancer rises to that of their colleagues in the United States. There are clearly environmental influences. It's not entirely worked out, nor is it strictly related to social class.
All right, we have talked about causes. Now, what are the methods of detection for prostate cancer?
The time-honored method, the one that's been used for the longest time, is the rectal exam. A physician puts on a glove, uses a little bit of lubricant, inserts it in the rectum, and feels the prostate. The prostate, as you recall, is right in front of the rectum. It's good for feeling the backside of the prostate. It's a little bit harder to feel things on the anterior or front side of the prostate. An area that's hard is suspicious for prostate cancer, but it also might be a collection of little stones within the prostate for which you wouldn't have to do anything. But it's suspicious and would merit a biopsy, sticking a small needle into it, taking out a tiny bit of tissue. Sounds terrible, it's a bit uncomfortable, but there are no pinprick receptors in the rectal wall, so it's basically an uncomfortable procedure, but not terrible and not really painful. In addition to this rectal exam, I'm sorry, did you?
Yeah, go ahead.
In addition to the rectal exam, in recent years there's been a blood test developed called the prostatic specific antigen test. The abbreviation is PSA. There's a lot of talk about it recently. It doesn't detect just prostate cancer. It detects abnormalities of the prostate in general, benign growth of the prostate, which most men get, will cause the PSA to rise a bit. There are two different calibrations to the test. One runs from 0 to 2.5 and another from 0 to 4. Anybody with a number above 10 on either scale needs to be concerned. But on the scale that runs from 0 to 4, where 4 is the upper limits of, quote, normal, numbers between 4 and 10 are a flag that you need to look further at the prostate, but it doesn't mean that you have prostate cancer. It's just that you have an increased risk of it. But it could also be due to benign disease. And you should go to a urologist and have it evaluated. The recommendations of the American Cancer Society is that, well, that healthy men without severe illnesses that would limit their life expectancy, but normal men between the ages of 50 and 70 should have a yearly review of their urinary voiding symptoms, their pattern of urination by a physician, as well as this blood test, the prostate-specific antigen, the PSA, and the digital rectal exam. None of these tests are perfect, and you need to use them in combination to get the best chance to know whether or not you need to be investigated further. Further investigation might be an ultrasound of the prostate, might even be a biopsy.
We talk about the biopsy, a PSA, and digital rectal examination. What about PAP? What is PAP?
Prostatic acid phosphatase, abbreviated PAP, is a blood test that we have before prostatic specific antigen. It's not very good at finding prostate cancer. The PSA is more sensitive in taking somebody who has no symptoms and telling you whether or not they have occult or hidden prostate cancer. But it goes up, the prostatic acid phosphatase test is more severely abnormal in people who have severe infection of the prostate or who have prostate cancer that has spread distantly. So if you've done a biopsy and know that someone has prostate cancer, and if the prostatic acid phosphatase is normal, then odds are that the prostate cancer is localized, and if it's elevated, odds are that it's spread. And this can influence your choices in management.
Well, among all this, biopsy is the most reliable method of detection?
Biopsy, if the biopsy says that you have prostate cancer, that is in fact the gold standard. With that, you can go on to figure out if it's spread or not and make a management decision or choice. But you don't want to just biopsy everybody. Mm-hmm. It's an uncomfortable procedure. It's costly. You know, it leads to some minor irritation. And it's expensive, I mean, compared to the cost of a digital rectal exam and a visit to a physician's office. Nobody wants to be poked with a needle if they don't have to.
How advanced is the research in this area?
A lot of things in the urinary, in the male genital system were ignored for a long time, just like in female genital system, because it was unfashionable to do research in it. It was not polite. But over recent years, more and more attention has been paid to it. And right now, there's a substantial amount of research going on in prostate cancer. It's Senator Dole's illness, like many celebrities' illnesses, has focused a lot of attention on prostate cancer and led to a little bit of increased funding and attention. There's still a lot we need to know, both about how prostate cancer comes about and in developing better methods to treat it, and even in trying to evaluate what we already use in treating prostate cancer.
I understand this illustration. You have a very interesting one. Can we find it and talk a little bit about it for our viewers? And here we have, this is a statistics, right? About
this particular illustration just underscores what we said earlier about the fact that prostate cancer is the most common cancer among all the cancers that affect men. The next most common cancer is lung, followed by colon cancer. It happens that lung cancer causes the most cancer deaths each year in men, followed by prostate and then colon. Lung cancer tends to be a more aggressive disease than prostate cancer. There's a lot of fear about cancer, and often it comes from diseases like lung cancer and pancreatic cancer, which are very rapidly progressing illnesses. Prostate cancer, though sometimes very bad, generally is a more slow-growing cancer and can be better managed. Now, I think in terms of referring to the interesting diagrams, you wanted to mention how we find if you have prostate cancer, if it's been found, how far is it spread? Mm-hmm. And that matters in terms of what sort of therapy we give. If the prostate cancer cannot be felt, but is present, which is illustrated in this diagram by a small lesion within the prostate, often very close to the urinary passageway, that's been called stage A cancer. If the prostate cancer is closer to the rectal wall, if the prostate cancer has not yet left the prostate proper, if you can feel it from the rectum, we call that a stage B cancer. B1 if it's small, B2 if it's more extensive within the prostate. If the prostate cancer has spread into an adjacent gland, the seminal vesicle, which also makes secretions to help sperm function properly, or if it's extended beyond the capsule enveloping the prostate into the tissues next to the rectum and the prostate, we call that stage C. The chances for controlling it are not as good once it's spread this far, but you are still able to control it. Now, finally, stage D, in this diagram, it looks like the prostate cancer is exploding. Stage D is when it's spread to the sidewalls of the pelvis, or when it's traveled to lymph nodes, or traveled to the bone. Sometimes even it metastasizes to the lung or liver. Those are the stages. We would like to be able to find, if it has to occur, we'd like to be able to find prostate cancer in very early stages, when it's still confined to the prostate. We have good reason to believe that we can cure prostate cancer if we find it when it's still confined within the prostate, either through an operation to remove the entire prostate or with radiation to the prostate. Once it's spread beyond the prostate, we can hope to control it. But once it's spread to the lymph nodes in the bone, we don't believe our current methods can eradicate it permanently, though we do believe we have good methods such as hormone methods to control it.
Okay, now I would like to talk about therapy methods for the prostate cancer. What are they, these methods of taking care? We know there is no cure for cancer at this stage, right?
For localized prostate cancer, stage A or B, it's just within the prostate. And there's always, with cancer, this chance that a few cells have escaped that you're not aware of, that they're sitting someplace to grow at some future point in time. But a large portion of the time, maybe 85, 90% of the time, if it's entirely within the prostate, a radical prostatectomy, an operation to remove the entire prostate gland, seems to succeed in curing people. And it's my understanding and experience that that is in fact the case. For people who have prostate cancer that's spread to the bones or to the lymph nodes, it's more an issue like in diabetes of controlling the disease as opposed to eradicating it. There's no good chemotherapy for prostate cancer that can eradicate the disease as you can do with some testicular tumors or with some lymphomas. But with depriving the prostate, depriving it of male hormones, which are important in the growth of prostate tissue and cancerous prostate, by taking away male hormones, the prostate cancer will shrink away. It won't eradicate entirely, but it will remain dormant for a good long period of time. The ways to remove the male hormones are to either take away the source, which is to remove the testicles, male castration, which is not a very popular way because of the psychological impact, or give monthly injections of luteinizing hormone, releasing hormone agonists. It's a big word. It means you give a medication that mimics the body's signal to the pituitary, and the pituitary normally then gives out a signal to the testicles to make a lot of testosterone. These injections that you give once a month basically prevent the testicles from making any testosterone by the way they act on the pituitary. In addition, the adrenal glands, little organs that sit on top of the kidneys, make some hormones that have male hormone effects, and you can take pills called flutamide or Ulixin, which block the effects of male hormones on the prostate. So this is a way of depriving prostate cancer the effects of the male hormones by eliminating testosterone produced by the testicles and by blocking the effect of male hormones made in the adrenal glands. And you can get very dramatic results in most patients if the prostate cancer is spread by using this hormone treatment. There's been some controversy as to whether or not it pays to do it very early on in the spread before it may be causing pain, but it seems that the earlier you do it, the more benefit there'll be to the patient.
You have a last question, Etienne?
Yeah, I would like to, as he mentioned, the psychological effects of people having that kind of cancer, I'd like to develop for our viewers, what is it the attitude of the patient when he sees that he has a sexual dysfunction?
The age range is from 40 to 90 in who gets prostate cancer, more centered around age 70. Not all gentlemen, as they get older, lose sexual function, but a large number do. but there's a very large fraction of men who have good sexual function when it's found that they have prostate cancer. A lot of men won't come for treatment or diagnosis even because they're afraid, they've heard that the treatments for prostate cancer will interfere with their sexual function. A lot of men feel that if they can't have an erection or can't have sex, that they're no longer a person, not a man, not a person, a nothing. And what I would say is that the various treatments for prostate cancer, not for benign growth of the prostate, treatments for benign growth of the prostate very rarely interfere with sexual performance. They may change your ability to have the sperm come out forward. That's in benign disease, but they generally don't interfere with erections, and they don't interfere with your ability to achieve climax or orgasm. The therapy for prostate cancer, unfortunately, is a little bit different. We do have good methods to preserve erections, in particularly the younger men who have no early changes in their sexual function, but there's still a portion that do have problems. When the disease is very early, when it's localized, when it tends not to be of the more bad type, there's a range of prostate cancers, the operation for removing the prostate can be done in such a fashion where the nerves to the penis are spared, and in about 90% of the time, the erections will return over the first year. The older you get, the older the patient is, the more extensive the disease is, the later it's found, the lower the chances of preserving the erection. So it's actually, if sexual function...
Dr. Weiss, I'm sorry, I'm going to have to stop you because the time is always up. If there is a last 15-second advice, what will it be?
Go once a year to your physician, tell them about what your urination is like, have a blood test for a prostatic-specific antigen, have a digital rectal exam. If an abnormality in these is found, have them refer you to a urologist. If you're a white American male and relatively healthy, do this from the ages of 50 to 70 once a year. If you're a black American male, do it from ages 45 to 70. If there's a male member in your family who's had prostate cancer, start about 5 years earlier.
Chers amis, nous étions en compagnie du docteur Gary Weiss. Il est praticien à Long Island Jewish Hospital. Il était ici avec nous à face pour parler du cancer de la prostate en compagnie de Étienne Télémac, notre documentaliste. We're going to say thanks to Dr. Weiss for being here, and we hope the next time he'll be available again when we call upon him to be at Face à Face. Thank you, Dr. Weiss.
Thank you.
Merci de nous avoir reçus. C'était Leslie Samedi qui vous a entretenu.